hopefully be mastered soon. Oh, you record that session. Maybe this is the first thing that I have to notice. We record this session, and we hope this is okay with you all. What I wanted to say is that that although we hopefully master the corona pandemic soon, the possibilities of digital meetings will continue to be a substantial part of our working and private life. So, and in addition, the corona pandemic has made it very clear how important the issue of health is. And even if the medical perspective currently dominates discussion, it is quite clear that health is not just the result of individual risks and their avoidance, but the outcome of a complex array of influencing factors. So next to individual behaviors, this includes social networks and the environment in which we live, as well as the societal factors. Schools are such a complex surrounding, which is located or nested in a bigger, more complex structures like communities, regions, or states. The SHE webinar series will look at different topics on school health promotion and hopes to contribute to the discussion and exchange of researchers, practitioners, policymakers from different fields of health and education. And I'm really delighted that today we start with a topic that could not be more timely. It's about mental health in and with schools. We are very pleased to have found two leading experts for this topic, which is Catriona O'Toole from Maynooth University and Vikram Patel from Harvard Medical School. So a warm welcome to both of you. We are really happy to have you today. So just a few words before we start with the webinar about the next hour. We are going to record this session, as you know, have recognized that, and we hope this is okay with you. Second, we would like to invite you to contribute to the discussion with your questions or remarks. So please use the Q&A function. So post your questions via the chat, and Jesper will take care of the questions and will give it into the discussion and ask the experts to answer these questions. And I was a little persistent in sharing a link with you with some introductory questions, and I hope that some of you took the possibility to answer these questions. And before we start, I would like to give you a brief overview on the answers. So I share my screen. It worked a few times today, so I hope it will work now as well. I hope you can see this. We asked you to answer two questions, and the first question was we asked you to rate how important you think the following health issues are for pupils or students since the outbreak of the COVID-19 pandemic, and we offered you four options or four aspects of mental health. And as you can see here are the mean values that range between 1 and 4, with higher values indicating a higher importance that you attach to these issues. And you see here that stress and coping seem most important to you when it comes to mental health of pupils and students, followed by internalized problems and behavioral problems, and substance use is also perceived as important, but not as important as the first issues. Maybe this is a little starting point for the further discussion. And the next question that we have asked you was, do you have a policy or strategy on a national, regional, or local level that focus on mental health in schools? And you see it's almost balanced between yes on a national level and no. So there seems no strategy or policy on a regional, local level, but if at all, on the national level, or even no strategy. Maybe this is also a good starting point to think about, do we need more strategies, more policies on mental health? So thanks very much for these two introductory questions. I will stop my sharing, and I would like to hand over to Margarita, who will introduce the speakers for today.
Thank you so much, Kevin, and I'm also very excited to start the SHE webinars. We have been talking this quite a lot of time, and now it's the right moment. And yes, I have a pleasure to introduce our speakers today, and I will do it by first introducing our first speaker, Vikram Patel, who is the Pershing Square Professor of Global Mental Health and Wellcome Trust Principal Research Fellow. And he comes from the Department of Global Health and Social Medicine, Harvard Medical School. He's also an adjunct professor at the Public Health Foundation of India, honorary professor at the London School of Hygiene and Tropical Medicine, and is a co-founder of Sangath, an Indian NGO, which won the MacArthur Foundation's International Prize for Creative and Effective Institutions in 2008, and the WHO Public Health Champion of India Award in 2016. He is a co-chair of the Lancet Commission of Reimagining India's Health System. The title of Professor Patel's presentation is Transforming Schools to Promote the Mental Health of Students, Lessons from India. So we are very happy to have you here and are very excited to hear your presentation. So please.
Well, thank you very much for inviting me. What an exciting forum you've created on schools. I'm going to be actually sharing work that I've been doing in India in schools actually for the past 25 years, but I won't be telling you about 25 years of work, but much more work that we've been doing over the last 5 or 6 years in partnership with the organization Sangath, which has really been the primary implementing organization, which is located in India. It's headquartered in the state of Goa, but in fact works across the country, as you'll see in a moment. I've been very passionate about the role of schools as a key platform for promoting the well-being and mental health and physical health and all other aspects of health and well-being of adolescents. Not least because this is a population which is rapidly growing in the sense that the coverage of secondary education for adolescents is growing all the time. It already exceeds more than 60 to 70% in most parts of the developing world, and it is growing all the time. And therefore, it offers a unique opportunity as a setting for providing a range of services for adolescents and young people. Why is mental? I want to just start with some background information, just to emphasize the importance of mental health for adolescents. This slide comes from the Global Burden of Disease data, which shows the relative proportion of the overall burden of disease that is due to mental and substance use conditions across the life course. And what you will see here is that the largest relative share occurs in young people from the ages of about 10 to 30. These are, of course, the age groups in which the most dramatic social transitions occur during the life course. If you look, for example, at adolescents between 15 and 19, and you add self-harm, which is classified separately in ICD, to mental and substance use disorders, you will see that about a quarter of the total burden of disease is due to these conditions. One of the metrics that is used to assess the burden of mental health conditions, which is widely collected in different parts of the world, is suicide mortality. And here you see data from India, which shows the patterns of suicide, the distribution rather of suicide mortality across the life course. And you will see, as in many developing countries, unlike the developed world, where you will see a peak that occurs in older age, in most developing countries, you in fact see a peak that occurs during adolescence and young adulthood. In fact, suicide is now the leading cause of death of young people in India in the adolescent age group. Just as a context also of numbers, India, of course, is the second most populous country in the world, but it also is one of the youngest countries in the world, so that the largest cohort of adolescents in the world are Indians, roughly about 200 million adolescents at this present moment. So this is a huge toll when you consider the large numbers of adolescents in the country. Now, if you look at suicide, though, as a leading cause of death across the life course, you will see that, in fact, suicide is a leading cause of death in young people around the world. Here is data from the other country that I spent a lot of time in, the US, which shows that in adolescents, suicide is the second leading cause of death. But if you look at the unintentional injuries, you unpack that, you will realize that a significant proportion of those could be misclassified self-harm events, certainly those related to guns gun deaths, which is, of course, a leading cause of injury-related deaths in the US. Another very important cause of unintentional injuries is substance use-related deaths, such as, for example, overdoses. And those, again, of course, one could consider as being mental health related. So if you really look at the leading causes of death in adolescents in the US, really the first and second are both strongly associated with poor mental health. And what's even more worrying, in the US at least, is that suicide mortality in young people has been getting worse over the last decade, and this is before the pandemic, increasing by nearly 50%. This is an astonishing increase in suicide mortality. And this is not only unique to the US, actually. If you look at England and Australia, two other OECD countries for which I could get suicide data, you'll find very similar increases in the decade ending just before the pandemic. So not only is mental health a leading cause of the burden of sickness in adolescents, but it is also reflected in suicide mortality being the leading cause of death in adolescents, and that these metrics seem to be actually getting worse in the decade before before the pandemic. And of course, the pandemic has made things even worse. These data again come from the US, and they show that right up until across the pandemic, up until February of this year, that the highest rates of self-reported mood or anxiety symptoms were in the youngest Americans, nearly reaching 60% of the sample in these household pulse surveys. What's very interesting is that you see a monotonic reduction in the prevalence of these symptoms the older you get, so that the least prevalent group is in fact the oldest Americans. This is of course interesting because many of us, when the pandemic began, we worried mostly about older adults, thinking that because of the risks posed by social isolation due to physical distancing policies and the resulting loneliness, that in fact mental health problems, particularly mood and anxiety problems, would be commonest in older adults. In fact, exactly the opposite is the case. So there's really something important about adolescents and young people that I'm trying to illustrate makes this a very unique developmental phase of the life course, which is associated with a much higher risk of mental health problems. I won't be entering into any conversations of why that is the case, but I'm happy to actually entertain that during the discussion. So I want to turn really to the way forwards, and I want to start first of all by acknowledging that I'll be speaking this is a very short talk, and I'm only going to be speaking about general principles and an example of a school-based program that we have been leading in India for the last many years. I'm going to draw on three different reports that I was centrally involved with. The World Bank's Disease Control Priorities Program for mental, neurological, and substance use conditions, the Lancet Commission on Adolescent Health, and the Lancet Commission on Global Mental Health. And I'm really going to draw together the key messages that really I can triangulate from all these three reports. And the key message is really pointed out on this slide, that really the emphasis for prevention of mental health problems, and that of course must be the emphasis rather than treatment alone. We must do everything we can to prevent mental health problems from occurring in the first place. And what's very clear is that the evidence points towards the targeting of harmful environments across the early life course. And I say across because we must remember that mental health problems that emerge in adolescence actually may often have their onset in terms of risk factors much earlier in the life course, oftentimes even in the first couple of years of life. And that we now know that there are a range of interventions, all of which act towards promoting nurturing environments during this early life course. Obviously, the environments will vary according to the age of the individual, so that in the youngest persons, children, the most important environments are the home environments, and so you would be really focusing on parenting interventions. As the child grows up and goes to school, those environments begin to expand to school-based environments and ultimately neighborhood-based environments. And schools, as you will see in a moment, has been the focus of a lot of my work, and certainly what I'm going to be talking about in a moment. What's very clear is that promoting adolescent mental health is everybody's business. It goes way outside the narrow confines of the health sector. At home, for the home environments, the strongest evidence base is for parenting interventions across the life course, but especially in the first few years of life, to promote early childhood development and attachment. A lot of these interventions are really focused in the first 2 years of life. For those of you interested, I won't be talking about this kind of this area of intervention. The promotion of responsive parenting, for example, within the nurturing care framework of UNICEF, is a terrific example of a policy document that really captures the key ingredients of home-based parenting interventions. But what I will be talking about is educational institutions. And within schools, the strongest evidence is around these three key strategies: promoting a healthy social environment in schools, teaching young people emotional regulation and problem-solving skills. These are both preventative interventions that work at the universal level or at the indicated prevention level, and providing mental health care to offer early interventions in the school environment itself. Again, won't be talking about structural and societal interventions, but again, we have a lot of evidence of structural interventions, such as, for example, promoting inclusive and progressive attitudes towards young people's sexuality, cash transfers, particularly to parents, to encourage them to send their kids to school, and a variety of other interventions that address young people's concerns. Now, what are the key challenges in scaling up this evidence? I think I've listed some of these challenges here, primarily because I want to illustrate how we've addressed these clearances in our school-based work in India. I think a fundamental problem is the very narrow binary biomedical framing of mental health, which clearly works very well for infectious diseases, but doesn't work at all well for mental health problems that tend to be much more transient, heterogeneous. There's no real clear boundary between mental health problems and being in good mental health. There are no biomarkers, etc. And I'm sure many of you who work with mental health more generally will recognize this problem as a fundamental challenge. We'll fail to tailor our programs to the needs of disadvantaged youth, minority youth. There's a lack of attention in mental health programs to social determinants and structural factors, so that we focus very narrowly on symptoms or psychological phenomena, but ignore the larger social world in which these occur. We rely too much on skilled providers. By this I mean mental health professionals, very few of whom will actually be available to work in school settings. And there is, of course, very importantly, adolescents are typically, it's one of those exciting phases of our life course when we really feel invincible. And alongside that, of course, is a great reluctance to seek help from doctors, nurses, other kinds of health professionals in healthcare facilities. It's with this in mind that over the last 8 or 10 years, we've built a suite of interventions to work in schools catering to low-income populations, either in big cities in India or in extremely less developed parts of the country, that really see the interventions for promoting mental health as a stepped care approach, interventions that target the whole of the school environment, interventions that target classrooms to raise mental health literacy, interventions that provide indicated prevention interventions for building problem-solving skills, and then finally clinical interventions for those adolescents who have sustained enduring mental health problems. And I won't be talking about the top one of this suite because that's outside the scope of my presentation, but just briefly tell you about all the others. So at the level of the school environment, we developed a program that has a clear theory of change, which you can see here, which was targeting school climate, which again is a widely used concept in school health. I'm happy to talk about that if there are questions around that. And what we really looked at was a range of different strategies that sought to engage young people in a participatory way to define the needs that they felt about modifying the school environment to make it a more pleasurable experience for them, and then examine the impact of that intervention on a range of risk behaviors, which included, of course, mental health problems. Here are some pictures. This was done in the state of Bihar, which is the poorest state of India, and we worked almost entirely in government schools. In fact, we work entirely in government schools in which 80% of the children were the first in their families to have reached secondary school. We published our findings of after 1 year in the Lancet and after 2 years in PLOS Medicine. Now, what you can see here is the dramatic effects of the school-based intervention that was delivered by a lay counselor, I forgot to mention that, both on school climate, but also on a range of secondary outcomes, including depressive symptoms, but also very importantly, on gender equity, as well as on the frequency of experiencing violence. At the next level of that step care pyramid is increasing demand for mental health care. And here again, we talk about demand within the school settings. Working with adolescents themselves, we co-produced a mental health literacy intervention that comprised an animated film followed by a guided discussion facilitated by the same kind of lay counselor who was in fact coordinating the whole school intervention. This was a single class period intervention, and we then conducted a step wedge cluster randomized control trial. I forgot to mention that the social environment intervention was also a cluster randomized control trial involving 75 schools. This was a cluster randomized control trial involving 70 classes in 6 secondary schools, and we reported a 50-fold increase in identified cases through self-referrals. And it's important, of course, in discussion to think about what was the important difference between these interventions and the ones that have typically been done. And the most important difference was that we did not use diagnostic labels, we did not use psychiatric terms, but instead really approached the question of mental health as a positive, valued asset rather than a disease biomedical focus. For those who sought help, we designed a brief intervention to build problem-solving and emotional regulation skills, again delivered largely through a medium that was very popular with young people, which is comic books. But here the comic books were supplemented by the same lay counselors delivering these interventions. We recognized what we really needed to do was to have very rapid interventions over very short periods of time, mainly because young people didn't have the patience to sort of engage with many, many sessions over several weeks. And this was the result of a lot of formative work that we had with young people. We completed a randomized control trial demonstrating, and this was published just last year in the Lancet Child Adolescent Health. For those of you who want to look at the design of the intervention, you also can see the reference here at the bottom of the slide, and we found that the counselor-delivered intervention outperformed just bibliotherapy quite significantly on self-reported problem severity, and we've just got the 12-month data, which shows that these effects actually even widened after 12 months. Quite dramatic, I think, for a 3-session treatment on average. We'll call it really a preventative intervention, showing sustained and enhancing effects 12 months later. We were so excited by these results, we've now adapted the same intervention for delivery in a gamified format, which can now be therefore delivered to all students, not just those who self-refer themselves. We've completed a cohort study with 250 students with no thresholds, as you can see, so it's a universal intervention, and observed very large improvements in symptom and problem severity. Our plans to do a randomized control trial unfortunately had to be stopped because of the pandemic, but we're hoping very much to actually start that trial towards the end of this year. Remember, this is an in-school intervention. This is not an online intervention. It's delivered in the schools, in labs, where, as you can see in the photograph below, young people come in for 3 to 4 sessions in the labs during either lab breaks or during the school breaks, lunch breaks, and they actually have their own private tablet-based delivery of the intervention. And finally, I wanted to just say something about the importance of engaging young people themselves in conversations about mental health more broadly. We think this is a very powerful tool through storytelling and engaging storytelling with the media. So you create a whole kind of a creative engagement of young people into conversations about mental health. I want to show you a short video, which may or may not work because I might have forgotten to share my sound. So I'm just going to actually share my sound and then show you the video.
It's not always easy to talk openly about our mental health, both our struggles and our victories. But when we do, we let others know that they are not alone. Sharing our stories with others can inspire them, offer hope, and help them. Manmela is a museum about young people's mental health stories from India. We feature stories from different parts of the country that tackle common misconceptions about mental health, highlight common problems, and share information on how to seek help and build resilience. Our storytellers work with a team of researchers, writers, and designers who help bring their stories to life using art and technology, enabling viewers to interact with their worlds as they travel through journeys of finding hope, identity, meaning, and empowerment. Our stories matter, and telling them can make a big difference.
So you can find you can find information, you can see the stories actually on www.manmela.org. I want to finish off by just giving you some guiding principles of action. At the level of young people themselves, key sets of principles are shown here, providing accurate information, restoring hope and avoiding a nihilistic, disease-focused approach, enhancing the agency of young people, including their peers, respecting their dignity and rights, and being always guided by evidence. So in closing, to reimagine school and adolescent mental health more broadly, we need to look beyond narrowly defined mental illness categories to embrace a diversity of approaches that are tailored to the needs both of groups as well as of individuals with special needs. We need to meet adolescents where they are, typically in educational institutions, rather than the traditional approach in adolescent mental health, which is to invite adolescents to come to psychiatric or other specialist facilities. We need to focus on the base of the pyramid of care through task sharing of psychosocial interventions to lay and peer counselors, and balance individual interventions with structural social interventions. And finally, and perhaps most importantly, youth must always be at the center of everything we do, from the design of those interventions, in fact, even before that, from what it is that they want interventions for, to the design of those interventions, their delivery, and holding the delivery accountable. Thank you very much, and I'll stop here.
Thank you very much, Dr. Patel, Professor Patel. Marita, I think that we will just move straight to the presentation with Dr. O'Toole, and then have the questions in the end, because I think that's will give a better discussion.
Yes, if that's okay for the presenters. Or all right, then I will introduce Catriona, another speaker from today, assistant professor from Maynooth University School of Education, Ireland. And Catriona is a chartered psychologist and assistant professor, and her research focuses on school well-being and mental health promotion, with a particular focus on childhood, adversity, and trauma-informed approaches. She is also interested in mindfulness, compassion, and contemplative practices, and her work explores how education can contribute to human flourishing and the creation of peaceful and equitable societies. She is currently working on a project to build capacity for trauma-informed practice across education sectors, supported by the Irish Research Council, a review of state of the art in school mental health promotion, and the UNESCO project Human Flourishing and Education. In addition to this all, Catriona is a member of the C Research Group. The title of her presentation today is At the Heart of Education, Integrating Trauma-Informed Practice within School Mental Health Promotion Frameworks. A warm welcome, Catriona. We are waiting to hear your insights of this team, please.
Thanks so much, Margarita. Thank you very much. It's lovely to be here and to get the invitation. So I am just going to share my screen with you now in one moment. Okay. So it was wonderful to listen to Professor Patel, and very much wholeheartedly echo and welcome his, what he's mentioned about moving beyond the biomedical and diagnostic approach. I was really excited yesterday. The World Health Organization published guidelines around this as well. And I think hopefully this can be something of a game changer in moving towards a much more psychosocial approach and in thinking about the determinants of mental health, which is something I want to pick up on in this talk. So what I thought I would do today is, I've been working around different things in terms of mental health in schools. But what I thought I would do is just to advocate for a better understanding of childhood adversity and the impact it has on mind, body, and behaviour, and to make a case for why we need to integrate trauma-informed practices or approaches within schools to better promote the mental health, but also the physical health, as we'll see why in a minute, and the educational experiences of children and young people. And I think given the damaging impact of adversity on children's health and well-being, it's kind of remarkable to date that researchers interested in well-being and health promotion in schools have had very little to say around childhood adversity and trauma-informed practice. So I'm going to try and redress that a little bit today. So childhood adversity is often and rightly sometimes referred to as a hidden pandemic, because it's so common and the effects so devastating. Indeed, leading epidemiologists now recognise that childhood adversity is a major determinant of ill health, and there have been calls to have it explicitly named by the World Health Organization as a risk factor in the onset of both mental health conditions and other non-communicable diseases. And linking to COVID, while I don't necessarily subscribe to the discourse around a mental health tsunami, we're hearing a lot about that. But what we do know is that COVID-19 has exacerbated pre-existing inequalities and has increased the economic, social, and psychological pressures on some children, and that is having an impact on their mental health. It's really the inequalities are a major factor. So firstly, what do we mean by childhood adversity? I'm taking quite a broad understanding in this presentation, and I'm using trauma and adversity quite interchangeably. First, so much of the research in this area has been instigated by the seminal Adverse Childhood Experiences study, or the ACE study, conducted by Vincent Felitti and his colleagues. And they categorized 10 different types of childhood adversity. These included physical, emotional, and sexual abuse, domestic violence, parental addiction, parental incarceration, family breakdown, physical and emotional neglect. And in their study, they've showed that around 2/3 of this was a relatively middle class sample, around 2/3 had experienced some type of adversity. And they also provided compelling evidence of the wide-ranging consequences for health and well-being. But we also, in addition to individual or personal trauma, we also need to understand and include within our concept of trauma the experiences of poverty, homelessness, discrimination, which are often experienced collectively by community members, and harm is passed down intergenerationally. And the causes of community and community trauma lie in historic and ongoing social inequalities, including poverty, racism, sexism, oppression, and other imbalances of power. And they can include things like erasure of culture and ethnic identity, forced displacement, and entrapment, and so on. So an extremely robust and consistent body of evidence strongly links childhood adversity to negative outcomes across the lifespan, including anxiety and very low mood, addiction, antisocial behavior, relationship problems, self-harm, and suicide. So those kind of mental health difficulties, but also childhood adversity correlates with a range of physical health conditions such as diabetes, heart disease, chronic respiratory diseases, and more. And in relation to school, it correlates with low academic attainment, learning difficulties, early school leaving, and school refusal. So with increased evidence about the health risks associated with childhood adversity and its prioritization by global health organizations, it seems important that researchers and scholars in health education consider the implications for school health, well-being and health promotion initiatives. The World Health Organization Health Promoting Schools Framework envisages school as a place where all members of the school community can work, live, learn, play together to promote the health and well-being of learners, of staff and parents, and indeed the wider school community. But childhood adversity is a significant barrier to realising this vision. Of course, we're talking a lot so far around data and health outcomes, and actually understanding the subjective experience of students and of children is vital also. So just for a moment, if it's okay to do so, consider what it feels like to grow up in unsafe, threatening or relationally impoverished environments. Karen Treisman uses the metaphor of a shark-infested waters and a desolate island to bring to life the lived experience of abuse and trauma. So children growing up in abusive, threatening, frightening environments may feel like they are trapped, outnumbered, powerless, surrounded by, big, fast, unpredictable sharks. Children experiencing neglect or living in relationally impoverished environments may feel like they're stuck or stranded on a lonely, empty, desolate island, feeling disconnected and invisible. And growing up, I suppose, in these type of environments activates the body's stress response system, which we know is that repeated activation and chronic activation of the stress response system is what leads to negative physical health outcomes. So that stress response system initiates a complex cascade of biological changes responsible for the flight, fight, or freeze response. And of course, trauma doesn't end when the danger has passed. Unprocessed trauma is held in the body and experienced as viscerally painful physical sensations, as distressing emotions, or vivid or fragmented sensory memories. So trauma fills us with a deep sense of dread, shame, self-blame, sadness, despair, and relationships are typically characterized by disconnection and alienation. And children who grow up in, who experience trauma typically have a narrow, what's referred to as a narrow window of tolerance, meaning that they have a lower threshold for high intensity emotion, which can cause them to become hypo-aroused, dissociated, withdrawn or shut down, or hyper-aroused, meaning distraught, panic, enraged. Both states obviously will interfere with children's ability to autonomously regulate their emotions, and it reduces their capacity to concentrate, to process and store information, with obvious implications for school relationships and school performance. Children typically will carry then these negative core beliefs that they are inherently bad, unlovable, or worthless. They may feel that people cannot be trusted, that the world is a dangerous or hostile place. And children then are carrying these beliefs inevitably into the school environment. So the responses of trauma-affected children may appear bizarre or incomprehensible to those who do not understand how abuse and trauma impact mind, body, and behaviour. They can cause children to get into trouble as staff misinterpret them as willful defiance or as a lack of respect or downright laziness. But the reality is that these are trauma responses rooted in deep emotional pain. And punitive consequences, getting into trouble in school, these punitive type consequences can be re-triggering and re-traumatizing, and reinforcing children's very negative views of themselves, or confirming their belief that the world is indeed a hostile place. So trauma-informed practice is has been advocated in many different countries as a way of supporting schools to create safe and emotionally healthy environments. Trauma-informed practice is about building knowledge about trauma and its impact on mind, body, and behavior. And the principles, the 6 principles of trauma-informed practice you see here: safety, trustworthiness and transparency, peer support, collaboration and mutuality, choice, voice, empowerment, and cultural humility and respect for diversity. So in essence, being trauma-informed means being aware that trauma is a very real possibility. It's about creating environments that offer a felt sense of safety, understanding the effects of trauma on the whole person, understanding how troubling behaviours and responses may actually reflect courageous attempts to cope with trauma. It's about maximising as well a sense of agency by offering choices, collaborating, validating, whilst being mindful of cultural, historical and gender differences. Another aspect of trauma-informed practice is it emphasises the self-care of teachers, of educators, and protection against secondary traumatic stress. And these principles then need to be embedded, or, you know, a whole school approach is envisaged here, so that these principles are embedded within the system as a whole, which means attending to school policies, procedures, curriculum and pedagogy, the school social and physical environment, staff development, staff recruitment, etc. And in this way, and indeed in many other ways, the principles of trauma-informed practice that you see here have much in common with Health Promoting Schools framework. And indeed, these principles kind of, there's a lot of synergies, I think, between these two approaches. And it's something that I write a little bit more about in a forthcoming paper in a book chapter that's due to be published soon. So basically, a trauma-informed lens that supports educators in appreciating the nature and consequences of adversity could support, enhance, or reorient school health promoting activities. For instance, young people who have experienced trauma sometimes engage in behaviours that may jeopardise their health, such as using drugs or alcohol, such as under or overeating. And they do so not because they're unaware of the risks, but because of the intense need to self-soothe or to gain acceptance or to numb or regulate intolerable feelings and emotions. So in the absence of a trauma lens, it remains all too probable that students will be blamed and shamed for their poor choices and risky behaviours. And rather than resorting to this kind of usually unintentional victim blaming, a health promoting school that's infused with trauma knowledge and understanding will be more likely to honour children's resilience and strengths and survival strategies, whilst using their policies and the relationships with the student, with families, with outside agencies to sensitively support and intervene as appropriate. There's a lot of challenges in this area. This is just a graph yeah, a colleague and myself have been doing some work in the area. What you see here is we're looking at attitudes related to trauma-informed care, attitudes and also readiness to embed trauma-informed practice. And the higher the score here, this kind of anything over 5 is, 4 or 5 is showing that across these across the graph here is showing, that there's generally demonstrating very positive attitudes to trauma-informed care, trauma-informed practice. But what you see, the grey here represents teachers, whereas the blue is other health and social care professionals. So what we're seeing is that in this study, which is Teachers in Ireland, is that attitudes are somewhat less positive than other sectors that are compared there in the other studies. So we've some work to do in this area, but just a take-home message: we are, myself and some some PhD students were looking at this area in terms of co-constructing, co-design, co-creating trauma-informed practices with schools that are tailored to their very unique context. And I think embedding that within, say, our own wellbeing framework, which is guided and informed by the Health Promoting Schools framework, is one very coherent way of thinking about it. So I think understanding and adequately responding to what happens when children experience traumatic experience is a basic requirement of a healthy school and a healthy society. And integrating then trauma-informed practice within health promoting schools framework needs to be seen with it and those broader efforts around educational and health equity. There's a lot of challenges to realizing this. It requires high-level commitment to addressing childhood adversity as well as systemic changes in many current school practices. Challenges, I think, will remain in terms of ensuring that trauma-informed practice is developed as more than just a set of tick box guidelines, and that's why we're keen to do co-creation work with schools, and that, you know, these practices become embodied in everyday interactions, and they're infused in all aspects of school life in very culturally responsive ways. So more empirical work and indeed conceptual work is needed in order to advance the breadth and depth of school trauma-informed work in these ways, I think. So I will leave it there and look forward to any comments or feedback or thoughts you may have. Thank you.